is Galaktion Makhviladze. I am oral and maxillofacial surgeon, implantologist from Georgia, and it's a great honor for me to be here among this panel, among these beautiful professionals from all world and in front of my colleagues. And thank you for coming and thank you for joining us. So, my today's topic is about the comparative analysis of diverse drilling pathways. It's don't need maybe to explain because all of us know how to put the implant, how to drill, how to make screw, how to put the screw in the bone, but we should pay attention on some details, which is very important to achieve 100% success. Why? Because these details make the predictable outcome, and then we can achieve the success in our everyday practice. So we will discuss our topic, and we will start with some information, some detailed information, and this is what is the success factor of the implant. And we know that we all need to have also integration in our practice. What it's the summary of some points. It's the implant design plus the bone remodeling around the implant, and thus it gives the osseointegration. But what is the osseointegration? This is the state of the implant directly connected with newly formed bone without any soft tissue. So let's go briefly understanding, as it was mentioned previously from my colleagues in their presentations, about the density of alveolar bone. We have this usual and conventional classification about the D1, 2, 3, 4. Even nowadays we are talking about the D5 density of bone. But bone density is a critical factor during our procedure because the clinicians, we can use the information certain by the drilling, by the doing osteotomy, and we can verify what kind of density we are dealing with, and then we must modify our protocol, our drilling procedure, how to make the implant in proper way, how to get the maximum bone implant contact, and this tactile feedback from the twist drill can provide critical information for us. Therefore, there is the key message from manufacturers that we must respect manufacturer protocols, and the goal we know, this is the 100 successful treatment outcome, but we also must pay significant attention, not only evaluation of the residual bone density and condition, but also we must respect the human biology and physiology. And therefore, on our way to 100% successful outcome and treatment results, it is extremely crucial to respect the recommendations from company, how to drilling and how to place the implant. So it means we have to respect the protocol. The protocol is the rule which gives us the possibility, which gives us the opportunity to have good and desirable results. So the target group in this comparison was Straumann BLT, Straumann BLX, Nobel Biocare, and Ostem implant, and I will go briefly through this protocol because all of us know how to deal with this bone, but we need to pay attention on the specific details from the neobiotech, from the Dr. Ho. With this unique concept, we can achieve the high results, and we will have even zero failure. So, in the case of Straumann implants, the protocol divided into 4 types based on bone condition, from very hard bone, soft bone, and very soft bone, as it was mentioned during the Dr. Monkol's presentation. So, and in very hard bone situation, always recommended to make the final drilling, cortical drilling, and taping. But in very soft bone, final drilling, just 2.8 is recommended, and 3.5 for dense cortical cortex only, and then placing the implants. In case of the BLX implants, there is 3 types of bone. They divided the bone is for 3 types. In first case, it was 4 types. Now it's the 3 types. Sometimes it's a little bit confusing, but they are saying like this, and soft bone needs just final drill 2.8, and then we can put even 4 millimeter diameters of implant. And in hard bone, we need final drill 3.7 diameters. So in like the same situation with Nobel Biocare Active and drill for cortical part in the soft bone, just drilling the cortical part, and in the dense bone, final drilling, and the cortical and screw tap is the option. So it depends on the clinician. If they want, they can tap. If they don't want, they will not tap. So it does mean that they can vary this protocol, but I think it is not so good idea, because I will go more and I will explain how it works. So, and in the ostium situation, we can make the full drilling and we can make the underside drilling. It depends on soft bone we have, hard bone we have, or medium bone we have. So, but in the case of NeoBiotech, Dr. Ho offers the precise protocol for evaluating the bone density, and there is 5 groups of bone density during our osteotomy. And it was mentioned before, we need to check what kind of bone we are drilling. During the drilling, we have to feel in which part of the implant bed we have what kind of bone. So group 1 was D111, D22. And the group 2 was D133 and D244. I will explain once again that D11 means that during whole body of the implant we have the hardest bone. It's a very strong bone. It's the cortical bone, and in the coronal part, in the middle part, and the inferior part is we are calling the apex. So we have the hardest bone. So it means D11. So in the 3 part of the implant we have D11. So to compare in the case of D44, it means that around the whole body of the implant, all CMI parts, we have just D4 bone. So these 5 groups has their own protocols. So in the hardest bone, we need final drilling. It's just 3.5 for 4 millimeter diameters of implant, and long taping, and cortical tape also. It means double taping we need when we have the hardest bone. And in the other situation, in the second group, we need final drilling and only cortical taping. As Dr. Ho said, cortical taping is not a lovely part for doctors, because we think sometimes that we are wasting time, but it's very important for precise engaging of the implant in the bed where we are drilling. So, and in case of D33, we need just final drilling, and in case of D44, we need undersized drilling. And we have one very important situation when we have the hard bone in the apical part of our implant. In this case, we always need full drilling, final drilling, and we always need long taping. So this is very precise details, which is very important in our practice, because without it, we will have bone trauma, we will have bone loss around the implant, and sometimes it turns to periimplantitis, and we will have failure. So we don't need it. All of us need to have success in our practice. Let's go and compare the bone implant contact between IS2 implant from NeoBiotech and BLX implant. So here is 2 scenarios of the drilling protocol in the case of surgical protocol with neobiotech eyes too. The first one is final drilling with countersink. It means the widening of the coronal part of the implant. And the second scenario, scenario 3, it means the final drilling with cortical taping. But in case of BLX implant, we have final drilling and cortical sometimes, and in case of only in cortical part, in the medium bone, and in case of hard bone, we need to make final drilling. Let's compare how it looks like in lab analysis. Now we can see in case of neobiotech implant, CMI implant, we mean, when we are talking about the neobiotech implant, we always mean that it is CMI concept implant. The CMI concept was explained by our colleagues very well, and therefore I will not waste your time to explain it once more. And we can see with the countersink protocol, when we widening the cortical part, we have the medium contact around the implant. But with cortical taping, we have more contact with the full body of the implant. When to compare it to the BLX implant, when we are making the final drilling, we have very small contact. And if we show it in numbers, the total area of ICE2 implant, surface area, I mean, it's approximately 30 millimeters. And the contact area from this protocol is for scenario 2, only with countersink, is 48 and 7.7 millimeters. And in scenario 3, with taping, it's almost 62%. It's very high results of bone implant contact ratio. Let's look it closer, how it looks like. We can see that not only the tips are with the contact in the cortical bone, but also the full threads are in the contact. And so thus we can, with cortical typing, can achieve the maximum bone implant contact ratio. And it is the highest one what we can meet in our practice, and this highest one we just have only with neobiotech CMI implant, and only then when we are doing our protocol like it is called CMI drilling and placement protocol. And in BAC rate in the other company, for example, in this case, we have just almost 38, almost 38%, and the difference is very huge. Now, let's see what is the problems with conventional implant. With conventional implant, we have the implant design problem, which is difficult to get the fine C fixation. As it was mentioned earlier, the C fixation is very important for any time loading. Coronal part must be in the contact with the bone to make the loading, and in this case the implant has very sufficient stability. And also the implant placement protocol that decrease the primary fixation. This is the problem which was recognized, weak stability of the fixture. This is the main problem, therefore it needs solution, and the solution is necessary for previous implant concept. And let's see now the crestal widening versus crestal pre-taping. As I mentioned, in this situation, the pressure when we are widening, when we just widen the crestal part and putting the implant insertion and fixing the implant, or just the crestal part and just tips of the threads are in contact with the narrow surrounded bone. So in this case, the pressure concentrated on crestal area of implant. And in the case of any time loading protocol with cortical pre-typing, we have maximum BA bone implant contact ratio, and in this case, overall pressure is distributed during the whole body of the implant, and therefore these implants are more reliable for such kind of loading, even in early, even in immediate, even in conventional type. Okay. And this is the graph analysis, the same, crestal widening and the crestal pre-taping. And we can see that with a full drilling and countersling, always we have pressure concentrated on crestal area. And with anytime loading protocol, with pre-typing, we always, overall pressure always is dispersed to the crestal bone. This means that implant drilling and protocol in any time loading situation means that there is no bone trauma, there is physiological pressure, and we have achieved maximum bone implant contact. Now let's see how to get, for example, ideal fixation in case of D144 bone. We need to make the cortical point, then full-size drilling, and in this situation we need to achieve two types of insertion: the active insertion in the soft part of the bone and the passive placement in the hard part of the bone. So we need to make cortical tap in the cortical plate because there's the hardest bone, and then go deeply and make self-compaction by the implant. Duet-to-implant design, it is very acceptable and it is very normal. So we can merge the implant precisely and we can achieve the maximum bone implant contact. So physiological placement protocol means physiologic pressure. And for maximum BIC contact, we need passive placement in case of D1 and D2 bone with short taping, and active placement in case of D3, D4 bone with undersized drilling, with self-typing, and with self-compaction. Therefore, anytime loading, K concept is the special implant design with, something happened. Special implant design plus physiologic placement protocol with cortical taping and surface treatment. Thus, three together gives us reliable and unchangeable primary stability, which is maintained during the healing process. To make this conclusion, I can say that anytime loading, drilling and placement protocol based on passive and active placement strategies for varied bone densities provides optimal bone implant contact, BIC ratio, with the highest precision. And the whole anytime loading protocol is founded on physiology with minimizing trauma and stress-free drilling procedure and implant placement. And to compare with the conventional drilling and implant placement protocol, all mentioned above, in combination with CMI concept implants, gives unique, unchangeable initial fixation without stability dip, which is most significant aspect for prosthetic loading whenever you desire. So, practical recommendations are provided for clinicians to modify the drilling protocol based on the specific bone density encountered during implant placement. Now we are sitting in the Leonardo da Vinci auditory, and Leonardo da Vinci said very beautiful words. I mentioned that I will talking about the details, and all of us here sitting and we are talking about the details. And details make perfection, and this perfection is not a detail. So thank you for your attention, and please.
Thank you. That was a very interesting comparison you made. If anyone would like to pick up on it and ask a question, or you can just freely start the discussion.
Please.
Okay. Thanks for your information, doctor. Can you hear me well? Okay. So I would like to discuss something about the dealing procedure. We knew that we need to avoid bone trauma, but I'm in doubt, especially with the protocol between BLX implant and maybe we can say IS3 amniotic in the soft bone. okay, if we follow the protocol that we call CMI and 333, it means soft bone, we still follow the protocol in full-length protocol. What does it mean? It means like this. Example, if we would like to place 4.5 implant diameters, in the Neobartic IS3, we will use 2.2, 3.0, 3.5 until 4.0 and place the implant down. If we face the problem of softest bone in 444, we will reduce the diameter to be under diameter. The final diameter is 3.5. So the difference between the hole and implant diameter is around 1 millimeters. I ever read the articles that say that, okay, in the thick cortical bone, you should make the hole smaller than the implants around 0.1 to 0.2. But with the soft bones, such as like the cancerous bone, sometimes it should be around 0.5 to 1. But just want to know that why do the protocol of BLX implant in the soft, maybe the softest bone, the final dealing burr is only 2.8 and place the implant down with 4.5 millimeters. The difference of the hole and implant diameter is around 1.7. My question is there any special procedure for this kind of treatment, this kind of dealing, or this kind of implant? Or is too much for providing the bone trauma? Maybe please give me advice.
Thank you for the question. As I mentioned, we have to feel what kind of bone we are dealing with during our osteotomy. So, in general, we not have always one kind of bone when we are drilling. For example, this is just the recommendations of how to feel when we have this kind of bone. When the hole is very small, always we have the problem, or maybe we will have the overcompression. In case of cortical situation, when as usual we have the cortical plate, yeah, when we have cortical plate, it does not matter where we have it, either in D4, in D3, it does not matter. Always we need to make larger this part in conventional drilling protocols. But in the CMI protocol, we are doing cortical taping, which gives us possibility to achieve maximum bone implant ratio and avoid the bone compression. And the next topic is that in the case of BLX implant, the neck area is the narrower than in case of our CMI implant. Therefore, our step is a little bit more, and also the one point. The neobiotech drills a little bit narrower than other implant companies' drills, and it gives the possibility to the CMI concept implant to make the self-compaction, self-taping during the implant placement, and also due to its unique anatomy, due to the unique design of CMI implant, we can avoid this bone compression. One main message is whenever we have the hard bone, we need to make taping, or sometimes double taping, and final drilling. And in case of D33, as you mentioned, Dr. Mankol, the final drill in the case of neobiotech, as I mentioned, is for 4 millimeters of diameter implant is 3.5. And as I mentioned, these drills are narrower than other companies' drills, so there is no necessity to make more steps. But in case of BLX, the implant neck is the narrower than in case of our implant. Therefore, this is their protocols. We're just talking for our about our benefits, what is from CMI drilling and placement protocol.
Thank you.
Thank you.
Actually, when you see the BLX is much more aggressive than CMI active. It looks like very active. But take a look at the final drill of Straumann for hard bone. It's 3.3. Yeah, it doesn't work. pick up, please. Okay. So it's the BLX is a very narrow core than the CMI, and the same diameter is 4.0, but the core is very narrow, which means it look like very, very powerful. But they use 3.75 diameter millimeter for final drill for hard bone.
Yeah, cortical plate. For
No,
cortical, yeah.
For the cortical bone, which means very little the amount of engagement of bone. So that means this is not good for immediate loading because it's very minimum BIC. But for CMI, we're using final drill is 3.5 for the hard bone, which means 0.5 millimeter difference. So which have more BIC, bone contact ratio. So don't confuse that, and also the Straumann they call the hard bone and medium and soft. So they don't divide the bone density in each depth. Okay, they just call this is hard bone, but we don't have homogeneous
Yeah.
bone density.
Around the
We never see bone
have
density
combination.
combination. So nobody recommend to recognize the bone density in each depth. So this is more precise, right? So we have to take a look. And also the BLX is come from 2019, right?
Yeah.
The CMI implant came from 2007. So it's a big difference. So we are sticking to the immediate loading, but the Straumann just follow late. So they just threw away their own concept of passive placement. So that's a difference.